Hello and welcome to All Coronary Physiology Cardio Webinar Series. Please subscribe to our channel to receive most recent webinars related to coronary physiology, assessment, and innovation. Thank you for watching. Welcome everyone. This is Alraies from Detroit Medical Center. And thank you for joining us on 8 p.m. Eastern Time and 5 p.m. Pacific Time to talk about the new dilemma, more complex patients and more cost constraints. This series coming to you from All in Coronary Physiology, which is sponsored by educational grant by Opsens Medical. We have been hosting multiple webinars talking about physiology and starting from techniques, tips and tricks, complex cases, complete revasc, COVID, and even now we're going to talk about the cost effectiveness in the cath lab. I would like to thank all of you who are joining us tonight, late night, as well as to thank Opsens for sponsoring this program. And today we're going to talk about, as I mentioned earlier, about the new dilemmas, more complex patients, and more cost constraints. This is a recorded program. Once we are done, we're going to be hosting this program on the Opsens YouTube channel, so you can go to this program at any time, along with the other program. This is our 7th webinar for this year. Please feel free to use the chat box to throw any questions at us, and as well as the speakers. We have lined up a great series of cases for you. So without further ado, I would like to introduce our speakers tonight. Dr. Wu, and Dr. Ang and Dr. Har, they're gonna have great physiology cases for us. Dr. Wu gonna, okay, thank you for sharing your slide. The focus of the program today is cost constraints, as I mentioned, and we're gonna see how using one physiology wire to complete your workup for pre and post PCI, and also to complete revascularization if needed. For that, with that, Dr. Wu gonna talk to us about complex PCI evolution under COVID-19. Dr. Wu is a Canadian medical graduate and is currently an interventional cardiologist who specializes in CTO PCI, complex PCI, and hemodynamic support. He is an international CTO proctor and also as invited speaker for many interventional cardiovascular meetings. His main publication involves CTO PCI techniques and is a contributor for several PCI textbooks. He's also a reviewer for numerous reputable cardiovascular journals. Dr. Wu, thank you for preparing the presentation, and thank you for being with us tonight.
Thank you, Chadi. Good evening, everyone, and I'd like to welcome all of you in North America. Now, when I first received the invitation to give this presentation, I initially declined for one main reason. I am not a coronary physiology expert, nor am I an avid user of the Opsens technology. But after some further clarification, it became obvious to me that what Opsens wanted was not for me to promote their product, nor the use of their technology, their products, but rather for me to share with all of you tonight my experience with complex PCI during the COVID pandemic. And as a matter of fact, when I was putting together this presentation, it dawned on me that coronary physiology actually plays an integral role in complex PCI during the COVID-19 pandemic. And I'll explain that as we progress on with the presentation. Now, I'd like to quickly look at the timeline because this actually affects what I'm going to tell you. So initially, December 31st, we all know reported cluster of cases in Wuhan from an unknown virus. Then the first person in Thailand is the first patient outside of China to have the COVID-19. Then 2 weeks later, the US had the first patient that flew from Wuhan to Seattle, then hospitalized for that virus. Wuhan's lockdown, then Canada, we received our first patient 2 days after Wuhan was locked down from a patient that returned to Toronto and was traveling between Wuhan and Guangzhou. Now, the most important timeline here is March the 11th. That's when WHO declared this a pandemic. And why is this important? If you look at the COVID publication and PCIs, you could see the trend. As soon as it was deemed a pandemic, publications start to rise significantly in terms of experiences, just to share around the world. People want to share the experience in terms of COVID and PCIs and how it affects the cath lab. And I'll use some of these data only. This won't be too data-driven because I know we want to make this clinical. So the first impact is the reduction in amount of ACS, and we all saw this in our practice in different hospitals around the world. 40% decrease in ACS, STEMIs or non-STEMIs, or any MIs. In Canada, we saw a 24% drop in a province, Ontario, in one of the province, Ontario, 24% drop. I also saw a significant drop in my hospital as well. And finally, in Italy, there was a significant drop in ST elevation MI, 40%. Initially, we all thought that it was because patients were inactive, they weren't that active, so they didn't have heart attacks. But we now realize they do have heart attacks. It's just that they do not want to contract the virus, so they delay seeking medical attention. And because they delay seeking medical attention, they have longer symptoms to first medical contact. And because we have to protect ourselves with PPEs, the time to PCI is a lot longer. So this is one of the major impact, and I'll explain how that affects us in the cath lab very shortly. And because of all these reasons, these patients come in sicker. They have higher ST elevation MI complications, including more mechanical and lower LV function. So that's the first thing you have to know. These patients are even more complex because they come in later. However, on the other side, we're affected because we had significant decrease in procedures, stable angina. So a lot of hospitals, if not all hospitals, would shift the attention from elective cases to emergent cases in order to have resources to deal with the COVID pandemic. There was also decrease in non-STEMIs and STEMIs, as I mentioned. So the volume decreased a bit, but keep in mind, surgery was not being done quite a lot. So PCIs dropped a bit, but we had to do more complex PCIs because surgery wasn't offering surgery at all. The next important thing to keep in mind is because of the pandemic, most hospitals, again, if not all, they had shorter length of stay in terms of ACS or any cardiovascular disease, 1 to 2 days as opposed to 3 to 4 days before the pandemic. And this comes into play as I will show you some of my cases. Finally, the most important for me and recent case experience is COVID-19 patients are pro-thrombogenic. So 28 case reports so far within last year of stent thrombosis when it comes to COVID-19 patients. So overall, what is the impact? And I'll go through cases with you. And that's what I was asked to do, is go through cases. Impact is a decrease in volume because of decreased admissions. Furthermore, physicians are reluctant to perform these complex PCIs. They want to keep it very simple and short. And in my mind, if you do this, you actually risk patient outcomes. So how am I going to justify, or how am I going to mitigate this impact? And again, I'm not a big user of coronary physiology, but I started to become a bigger user. And I'll explain why. Using coronary physiology, we know helps patients. And that's why I started using it more. We know from FAME 1 that we are not good at predicting lesions. 37% of the time we're wrong, maybe more in real world. We think it's severe, but 37% was not severe according to physiology. And if you look at the actual number of stents you put in less stents for these complex patients, multivessel patients, if you use coronary physiology as opposed to more stents. And again, because these patients are pro-thrombogenic, you really want to keep the number of stents to a minimum. And finally, I'm very comfortable, since I see this data, that if I use angiographically versus coronary physiology guidance actually have a MACE benefit. So patients have better outcomes with coronary physiology guided PCI. So that's the background of how pandemic has affected complex PCI and how I'm able to mitigate those challenges with coronary physiology as well as other things. Okay, so let's first, I'll have 3 patients for you. The first is stable, then I'll go to non-STEMI, then STEMI patients. So the first is an outpatient. So again, we tend not to do these patients because of the COVID pandemic, but this patient is very symptomatic. Very complex CTO, and I'm not here to talk about CTO techniques, but I want to briefly go through it just to illustrate a point. That's the right CTO. The patient also has concomitant. Doesn't look very bad on this view. Some other views, and I don't want to go through all the views, looks borderline, maybe severe if it includes the proximal part bit as well. So we left that for now. The patient's so symptomatic that we did a retrograde. And for those of you who doesn't know what a retrograde or not familiar, we went down the LAD, cross the septal, backwards to RCA to get to the distal cap. And this is the Sion wire crossing the septal right now. It's what we call septal surfing, cross to the PDA there, then backwards to the RCA. Once we are there, we start what we call is a vessel dissection from the retrograde wire. Then we try to complete what's called a reverse cart. Regardless, I'll show you what that means. So we couldn't do it there, so we move our base of operation distally. And exactly what this means is we are able to connect the dots so that we could externalize the wire from the left out to the right guide, and on that externalized wire, delivery gears. So very complex outpatient case. So far, we still have residual stenosis here. So what we did was, in order to access the side branch, we use a dual lumen microcatheter. If you look on your left diagram, in order to access the side branch. Once accessed, we then complete this case. So the whole point here is this case is very complex, very long. Now we have other lesions to deal with. I have this LAD 2.5, and what we have, and I've seen this is operative fatigue as well, especially during the pandemic. So what I did was I did an IFR and it was 0.98. So it's not severe. That shortened the case a little bit, as opposed to going on to a 3-4 hour case, potentially getting to a complex LED diag bifurcation without knowing that it actually needs it. That's a very simple case. Now, a more complex case is this gentleman.
Can I ask a question, Dr. Vu?
Yes,
so, yeah, so if you go back to that case, let's say the IFR or the FFR was significant in that LAD, would that you change your strategy for that CTO?
That would not have changed just because the patient's so symptomatic, Chadi. And it's a good question. We know from data that if you do a coronary physiology FFR of the LAD with the CTO in place, you tend to overestimate the coronary physiology. So it may look severe in the LAD, and once you open the CTO, then it's no longer severe. So that's why we did that first, then did coronary physiology afterwards.
Perfect. I just want to highlight that part to the audience. Thank you.
Perfect. Thank you, Chadi, for bringing that up. So this is a non-STEMI patient. Came in with a non-STEMI, admitted to hospital. Again, because of COVID, and especially the third wave, they really want this patient home. So that's the right. Then I look at the left. Angiographically, it looks horrific. You know, you got the left main bifurcation. You have the mid left circumflex severe lesion. Now I'm scratching my head. And I'm a complex operator. This is my my area of passion. So I really wanted to now proceed with complex left main stenting. Surgery wouldn't offer it again because of the pandemic, shorter beds, ICU is full. So what do? I had the fellow with me and I said, you know what? Before we do anything, we really want to make sure that these are severe lesions. They look severe, but let's make sure. Before the pandemic, I would have proceeded to rebook this patient with complex PCI. And I'm being straightforward with you. Now, because of the pandemic, I'm pushed more to justify my cases. Proximal LED lesion as well looks severe. So I said, you know what? Let's do the IFR of this lesion. It's not severe. Everyone was shocked. I was shocked. We did pullback, multiple, normalization, everything, not severe. And again, I'm not a coronary physiology expert, so I was shocked. I did just the LAD into the diag, again, not severe. So made me smile. Now this patient, non-STEMI, this one was severe, 0.88. I did a pullback. Most of the jump was at this lesion. So what did I end up doing? Instead of complex left main bifurcation, all I had to do was the LAD and the patient went home and still doing well. So I am still in awe of this kind of case for coronary physiology, and this kind of simplicity that it brought to my patient and myself gave me a sense of relief. I don't have to spend 2 to 3 hours on this complex case. Now,
Dr. Vu, this is exactly highlight the point you said with the FAME trial, they excluded 37% from stenting. So that's exactly, this patient falls in that category. I mean, that's an excellent illustration of that.
Thank you, Chadi. And please, yes, you guys are the coronary physiology experts. Stop me anytime. My is mainly the PCI part. So from that case, I'm thinking, you know, what if I were to do complex stenting? And I learned from this is my recent case just this week. This 60-year-old gentleman with a STEMI and COVID pneumonia. So he comes in, he's got PDA, PLV disease, severe, potentially ostial left circumflex disease, and severe LAD disease. So this is a very complex lesion. It's complex, it's ruptured. It was not wire dissection. It was angulated. Again, for these angulated, if you look at left, if you were to wire these and you keep pushing, it will keep prolapsing because the force is forward. There's no way you're going to get this with regular wiring. So we did a Supercross 120 with a microcatheter. You could see there on the left and right of your screen. I'll let that run for a bit more. With that microcatheter pointing the right way, we were then able to access this proximal LED. Once we access, you can see there, it was difficult to get to the diag to the LED itself. We got the diag just from the Supercross. We switched for a dual lumen microcatheter. Then we stented this patient, and we were happy. Now, there's residual disease in the circumflex, as I told you here, as well as the PDA and PLV. Okay, this is in the setting of a STEMI. So again, my reflex is not coronary physiology because that's not me. My reflex is complex PCI. So I refer this gentleman for complete revasc. He did not receive complete revasc from a colleague stating he had pneumonia. He should go home, see how he does. He came back 2 weeks later with stent thrombosis. We all thought, nothing to do with COVID. It's just the patient. He's stent thrombosing. He did miss 1 day of Plavix, ticagrelor. So maybe that's the reason. So that was treated with 1 stent by a colleague. Again, no coronary physiology. He decided to treat the ostial left circumflex, whether rightly or wrongly. Again, no coronary physiology. Look kind of severe. So when he treated those, 5 days later, stent thrombosis of both stents. So now I'm thinking, when he came back, I'm thinking to myself, should the left circumflex have been done? Probably not, maybe not. If we did coronary physiology, we may have escaped with it. But now he's got 2 stent thrombosis. He's sicker than ever because, again, I truly believe this is from pro-thrombogenic state from a COVID patient. So then we ballooned. We got this thrombus in the left main. Just for completeness sake for the audience, 3 days of integralin, it embolized distal in the LED, and now he's left with this. Left main, left circ stented. What do I do in a COVID patient? And I still don't know, but we treated him conservatively for now. We left the right, and I will bring him back for physiology of the right. Again, that was not my reflex because that's not in my DNA. My DNA is CTO and complex PCI. So what have I learned from my experience so far, and that I'd like to share with you and hear from feedback from the panelists, Chadi, and all of you tonight is complex PCI truly needs to evolve. I've been doing complex bifurcation stenting C2 all the time without coronary physiology, but learning from the cases I've shown you, we need to evolve and get better because I feel comfortable with the data. And by incorporating physiology, I think this is essential during COVID to simplify everything, to prevent complication like stent thrombosis. And even after the pandemic, this is the right thing to do. I think for myself, that's the key thing that I've learned putting this slide together. So I appreciate the opportunity to give this talk because I learned from the talk myself, very interestingly enough.
Thank you, Dr. Vu. That is a very great presentation. It really highlights a few things. It's very important. Beyond the specifics of the wire, is, as you said, you have to have for the cost effectiveness, you have to have a reliable wire that can complete the job and also give you the answer quickly and reliably so you can make the next decision for this patient, especially in the constraints of COVID-19 with the financial burden, as you nicely showed in the beginning, the drop in volume. A lot of hospitals got kind of really jeopardized from that. And therefore, you have to kind of put your budget in the equipment that you really trust the most. And beautifully illustrated that. And thank you so much for bravely presenting your last case. All of us has one of these cases in COVID-19. I had it one as well. And we had a patient, came late, stented, but thrombosed, and eventually LAD is gone. I mean, there's no way to salvage that vessel. And if you're not cathing in COVID, definitely you didn't see it. But if you are cathing in COVID-19 pandemic, definitely you have one of these cases, unfortunately. Dr. Ang, Dr. Har, any comments?
Yeah, I like that last case. I think that your colleagues, not to cast aspersion, but rather than reaching for a stent to treat the circumflex, maybe it would have been more cost effective to reach for a FFR wire for the circumflex and IVUS for the LAD. And it would have saved some headache down the road.
That's true. That's very true.
I think this case also illustrates very nicely, Dr. Vo, you showed someone with COVID, developing likely a stent thrombosis from the prothrombotic state. But, as well, like there's a lot of new infections that happen as well, and patients are coming into hospital to have their procedures done. So certainly there's a risk of infection when they visit the hospital. There's been a number of hospitals where there's been infections between staff and patients and between patients as well. So, you could have a patient that would come in healthy, and then whether in the community or during their stay, they get COVID, and then they would end up being at risk for developing a stent thrombosis, as you've illustrated. And certainly I've seen a couple of cases of that prothrombotic state as well. There was a patient that came with an anterior STEMI that was altered level of consciousness. I opted not to take to the cath lab because we didn't know how long they were ischemic for. And subsequently on their echocardiogram, I presented this at a different meeting. They had a very large thrombus, pretty much taking up the bottom apical third of their left ventricle. So fortunately, we didn't cath the patient and instrument their left ventricle, because otherwise we would have embolized all that up and caused a stroke.
Right. And I want to throw a question to the audience. Have you been using more 2B3 inhibitor during COVID-19 due to the thrombus burden? Dr. Vo, Dr. Hart, or Brian, or Ang?
Oh, for us, yeah, I noticed there's higher thrombus burden, Chadi. But before we discuss that, I just want to clarify. So it's a good point you brought up. The main reason why I don't use a lot of pressure wires, because for complex operators, we need good support on our wires. And I haven't had good wires. I've tried the Opsens wire, but I don't have, we don't have the Opsens wire, so I can't comment on that. But the wires I've used so far, they're just not good support wires. So that's why I don't like using Physiology, because then I have to do that, use another wire, and so forth. So that's a good point. They're not good for support for complex cases. In terms of Integralin, I'm using more Integralin without realizing that I'm using more. Once you brought it up, yes, I'm using more. And again, from these cases, I learned now to pull back on complex stenting, only stent when it's truly necessary, which means you need to do coronary physiology. There's no way I could trust my eyes anymore from those cases. And these are recent cases.
Right. Yeah. Thank you so much. We have a poll here for since the start of pandemic, how would you rate the complexity of most patients you see? And majority answered is some of my patients are more complex. So complexity increasing, we're getting just the sickest of the sick, and who are really require a lot of work. And sure enough, and we're having a lot of presenters again now here in Michigan because of the COVID peaking again. All right, well, the next speaker is Dr. Lawrence Ng. Lawrence Ng is assistant professor and interventional cardiologist at UC San Diego. He conducts research on medical advancement to improve cardiac procedures and patient outcome, including state-of-the-art robotics, intracoronary hemodynamic, pulmonary angioplasty, and serum biomarkers. Dr. Ang, thanks for being with us. Thanks for preparing the presentation, and the platform is yours now.
Thanks for having me. Good afternoon and evening to all of our guests, and to Dr. Vo for just kicking us off on a great start. I do a lot of FFR. I did about 150 last year. I'll say that as opposed to Dr. Vo, a lot of my procedures are on the simpler side, and a lot of these FFR procedures are for research and transplant patients. In my presentation to you this afternoon, I basically want to do two things. I want to present some of the data behind FFR cost efficacy and share a case with you all. And I think the biggest question that we ask ourselves tonight is FFR cost effective? And basically, I would say yes, and the evidence suggests this, but depending on the situation, there's a lot of variability between patients and our operator behavior.
Get ready. Thank you.
The costs that we find ourselves faced against, either equipment or reimbursement, and the time window that we're analyzing the data within. This is data from the FAME trial. At 1 year of follow-up, using FFR guidance improves patient outcomes and saves money. And what's this due to? So even though you spend money up front to use the pressure wire and adenosine, you end up saving money by decreasing the amount of planned stents that operators wanted to use, as well as decreasing costs from repeat hospitalization, PCI, cabbage, or complications of MI. When we look at FAME2 data, now this is for FFR values less than 0.8. If you stent up front, now patients tend to do better than if you medically manage. And in terms of cost efficacy, spending money up front for FFR and treating with a stent eventually leads to improved patient symptoms between 1 and 3 years after your stent. And those who received medical therapy alone, even though their index procedure was initially cheaper, ended up having the same cost overall by 2 and 3 years after the index procedure due to repeat revascularization and coronary angiography. Now, going from stable CAD in the FAME trials to STEMI, the famous STEMI randomized trial looked at those with single or multi-vessel CAD and how FFR changed initial treatment strategy based on angiography alone. And overall, use of FFR in these STEMI patients led to more medical management and less cabbage and PCI. And what the investigators saw was that by 1 year, patients did the same by receiving more medical therapy, even though, and I'll say that the cost was the same between both the medical therapy group and the costs were the same between angio guidance and FFR guidance, even though the FFR guidance needed use of a pressure wire. So basically more medical management, even though you had to use a pressure wire. And then we'll move on from STEMI to STEMI patients. In the Compare Acute trial, those who had FFR guided complete revascularization compared to revascularization of the infarct-related artery only eventually had cost reduction by 3 years after the index procedure. And this is driven mostly by reduction in 1 to 3 year major adverse cardiac events. I will note that there is variation in the cost of the index procedure and overall cost reduction based on which countries were reporting their costs. And this is just an overview of all these clinical trials. And there's variation in the cost efficacy that we can see. It varied between FFR leading to lower costs or the same costs, and patients having improved outcomes or similar outcomes depending on the comparator group. But in none of these studies did FFR show that it was cost disadvantageous. Another question that comes up is, how can we as operators improve the cost efficacy of FFR when we're using it? Now, when the FAME trial initially came out around 2010, investigators from Vancouver General Hospital noted that their index procedures using FFR were more expensive in theory compared to using angio guidance alone. There was also more opportunity for FFR to change management in those with multi-vessel disease, but you'll note that these yellow numbers are greater than the green numbers when angio was used. And they attributed this cost increase with FFR due to the behavior of the interventionalists that were used to test treatment. And in this group of interventionalists, rather than like the FAME trial where every single intermediate lesion was planned for stenting, these interventionalists planned for medical management in many of those with FFR less than 0.8, and that's highlighted by these red circles. So they had an opposite treatment approach with medical management. And so that's the reason why there was less cost saving. And I'll just note that we now know in the last dozen years, since FAME2 came out, that if you have a FFR less than 0.8, those patients in the red circles should have received PCI based on FAME2, and patients with an FFR greater than 0.8 who underwent PCI here, those patients, according to the DEFER trial, would eventually come back with restenosis and possibly myocardial infarction due to that unwarranted stent. So these investigators wanted to know, how can we better utilize FFR in each case? And they identified several factors during the procedures that could have informed them if FFR was likely to be negative or positive in each case. They identified multivessel disease, diameter stenosis by QCA, lesion length, and haziness of the lesion appearance as significantly predictive of FFR results. They gave different points to each of these risk factors. And basically, if you had less than 2 points, it's very unlikely for your FFR to be abnormal. So that's an opportunity for cost saving. I'd just like to end with a case example. And this is the case of a 60-year-old woman with diabetes, hypertension, and hyperlipidemia. She presented with crescendo angina on medical therapy. Her stress MIBI was negative, and she has a normal EF. The right coronary artery, as well as the left circumflex artery seen in these angiograms, did not have significant disease. But if you observe the LAD and the diagonal bifurcation, I would say that there's moderate disease in the mid LAD, about 40 to 50%, and a very short but high-grade stenosis in the proximal diagonal branch. So what I did in this case was FFR, the mid LAD, and the diagonal, and these are the results. So the mid LAD, right after that lesion, but before a segment of bridging, had an FFR value of 0.89. And so I think that's just a very interesting result, because you might look at this mid LAD lesion here and think, that's not severe. That's a lesion I would ignore. But an FFR value of 0.89 is definitely abnormal. I mean, it's not 1. So it's also not less than 0.8. So this lesion is solidly moderate, and only by using FFR information can you just determine that it's right between normal and significantly abnormal. Now, this short diagonal lesion led to a FFR value of 0.62. It's drastically abnormal. And sometimes with these very short lesions, the FFR result is unpredictable. But here, now I know in this patient with angina that's been worsening on medical management, as well as a negative stress test, that this diagonal lesion was the culprit and we needed to stent. So here we have 2 wires in the LAD and diagonal. And because the lesion is so short, we can get away with a very focal stent right between the 2 branches, sparing the diagonal ostium, staying away from the carina of the LAD and the diagonal branch. High pressure inflation. And here's our final result. I will note that the resting index for the diagonal went from 0.75 to 0.93 by the end of that focal stenting. So I think using FFR in this case was very helpful, because it just simplified things tremendously. I didn't need to upsize my sheath, use a 7 French guide, do bifurcation stenting with maybe a complex configuration, maybe a V stent, maybe something else. So it just helped me to target the culprit lesion and get the job done. So I think in overview, FFR cost-effectiveness by the data that's available to us has been demonstrated in various contexts, single to multivessel CAD. stable CAD and STEMI. Cost effectiveness may also be more apparent in multi-vessel disease where our index procedures can be more impacted by FFR results, and outcomes in 1 to 3 years to 15 years after the procedure can be optimized. And furthermore, the cost efficacy from FFR may be improved in the way that we choose to use the device and the information. Thank you very much for your attention, and take some questions.
Thank you so much for your help. From what you read during your preparation for the slides, is there any specific comparison between certain equipment that has been shown to be more cost effectiveness in coronary physiology?
I've only come across one other paper comparing FFR and OCT, and honestly, it was beyond the scope of this talk. But I'll just say this. I think FFR is the gold standard for determining if a lesion is causing ischemia or not. When you look at IVUS, for example, all the minimal luminal area or minimal luminal diameter results have been correlated against IVUS. Against FFR results. So FFR was used as the benchmark for intravascular imaging. Furthermore, I was going to make one other point. I just can't remember. But
I have another question for you also, or Har, is now with the constraints as we entitled this session is of the finance and also I don't know if you face that same thing, difficulty making decision, bringing patient to the lab because you don't want to expose them, or if they're COVID positive, you want to bring them to the lab is very challenging. Not because the staff giving you a hard time, but also I make sure you are making the right call to bring this patient down to the lab to do an angiogram and want to be a very appropriately indicated case. Not just angina that can be resolved with beta blocker and mDOR. So don't you feel that our utilization of resources, I want to have something really reliable in the labs to give me the best answer before I take this patient off the table so he or she does not come back to the lab for any future revasc?
I definitely think that having reliable information is useful. During COVID, we've tried very hard to be judicious about who comes, but at the same time giving treatment to whoever needs it. I think while you're in the lab and you're all gowned up and if you know exactly what needs to be done by the end of the procedure, i.e. doing FFR in multiple vessels or intermediate lesions, that's definitely better in this era of COVID, particularly for a COVID patient, rather than bringing them back to the lab and doing repeat angiography or interrogation. But we definitely have brought back COVID patients once they get better.
So now we have a question here in the poll. How would you rate the importance of containing cost for your administration? Myself, I'm going to pick B as well. With the pandemic, my hospital is putting much more pressure on cost. By this is not impacting my practice. I would say it's maybe still a little bit impacting my practice as well. The way administration, and this is rightfully so because COVID kind of affected a lot of finance and income to the hospital. But so that's why they are becoming more stringent. Anybody has any different thoughts?
I'll be perfectly honest. I don't know. I come from an academic center. I don't know the cost specifically for every case. And what I try to do is use the tools to give the patient the best outcomes as possible. And I do think that in using FFR, the cost will fall on the beneficial side of the scales at the end.
I have a question here. The financial benefit depends upon the prices paid. In my practice, a pressure wire is 3 times the price of a single drug-eluting stent. Is that true for the US?
So in the FAME trial, the cost of the stent was about 3.5 times. It was $600 to $2,000. So yeah, those two metrics matter for your cost efficacy analysis. In the Vancouver General Hospital study, the discrepancy between the two was about the stent costing maybe like 1.5 times more than the pressure wire. So those cost differentials matter when seeing if your FFR usage is cost effective or costly. Yeah.
I think, Chadi, I think his question, because I know Steve from within the community, I think what he's trying to ask is, what is the current cost of your coronary physiology wire in general and your current drug-eluting stents? Because our stent is now very low cost, maybe $300. You know, our FFR wire is 3 to 4 times that. Yeah. So I think we're just trying to understand the actual clinical practice rather than what's in the study. So would you guys be able to answer that for him?
Well, in terms of cost, I don't have that numbers off the top of my head, but I would like to be. I don't want my patient to be fall in the 63% that you showed us on the FAME-1 trial and put a stent that he or she does not need. So sometimes physiology is not about how bad it is, but it's about exclusion of therapy, and maybe this patient does not need it and they will be done with the procedure. Maybe it doesn't need a stent. So maybe it's on the long run, maybe a cost effective, but in terms of the price of the equipment itself in the US comparing stent to R, maybe I would get that information.
Yeah. I think Dr. Ang presented it quite nicely. The upfront cost, if you do, FFR, IFR, DPR, may be higher. Because you do need to use that wire and use the adenosine potentially. But then on the flip side, your repeat hospitalizations and repeat and your adverse events are lower using physiology guided PCI. So your cost savings will potentially come out in the long term. It's not an immediate payoff on your investment, but it pays off in the long term.
And I think your reimbursement for your equipment also comes into play. If you have fixed reimbursement, then yeah, you're counting every single thing that you use. But if you have reimbursement for each piece of equipment, it makes things a lot easier.
So I'm just gonna push the topic just one more time here. Fine, all the data shows it's cost effective, but I'll tell you, as a complex PCI operator, the hospital is always looking at my cost. So each of my PCI, regular PCI is less than 1,000. My CTO can go up to 10,000. They're not thinking about, is this patient gonna come back 10 times or not? I'm gonna tell you right now, okay? Realistically, in real life, they're gonna say, each of your case now, you got an FFR wire, you got the IFR, you got this and that. Each of your case is double everybody else on a daily basis. They're not gonna say, well, the other guys have these patients coming back. They're not looking at particular patient, how they're coming back. So I think Steve is trying to say, if I have this patient in front of me, now, do I pull out the FFR wire? Then if I have stent, now I spend 1,000 plus 300. Or do I just go $300, boom, patient out, my cost per case. So how we look at is cost per case. We don't look at cost per patient coming back, right? Yeah. So that's real life. And it's hard for us as an operator. And again, I'm not coronary physiology, so I don't deal with any of these. I deal with real life. I deal with more practical, right? So how do you rectify that for the audience? If they're looked at,
you raise a very good point there, Dr. Vo, because the costs are siloed, right? So they're only looking at individual costs. And for the same argument, right? If you're preventing a patient from needing CABG, they're only looking at the fact that your hospital stay might cost $10,000 for a complex multi-vessel CTO procedure, and the patient goes home same day or next day, and then the patient can spend a week or two, depending on if they have complications after CABG, right? But they're not looking at that. They're not looking at the fact that it's a 6-digit to 7-digit cost to go through CABG in that situation. That's the unfortunate reality of our situation, is that people are only looking at those siloed, not able to separate the trees from the forest types of costs.
And then for the payer, here in the States, ultimately, there was a push to make those who did an index procedure accountable for 90-day events in the future. And so it really, in that system, it really pressured you to make sure that outcomes were optimized. So it really depends on the payment paradigm that you're up against. And I do think that from your administrators or your hospital business people's standpoint is a little bit short-sighted to avoid outcomes.
And this is a very good call. I mean, I just want to clarify, Charles just texted me saying that in the US, DES is almost in price like pressure wire, but in Canada is 1/3. That drug release is 1/3 of the cost of the pressure wire. So that's one thing. The other thing is, which is Dr. Rose is bringing very important, and Stephen Ford is, we don't have cost per case. We should implement this in our labs and every lab as well. We don't have it. Our cath lab directors mentioned it once before that maybe we should do it because other health systems doing it. But that's also important for us to learn. We are leveraged to having everything at our disposal. We can call any equipment we need. We can open an impella to do a left main, yet in Europe, they don't do it. You do it with one wire, one balloon is done out. So we are privileged to having all this. But again, at the end, this is put a big burden on the system and the cost. Thank you so much. This is a great discussion. I want, for the sake of time, I want to move on to Dr. Brian Haar presentation. He's going to talk to us about the cost effectiveness complete revasc with a single pressure guide wire. Dr. Haar, he's a clinical assistant professor at University of Calgary, Approach Research Group, head of Foothills Interventional Cardiology Clinical Trial Group, and interested in intracoronary imaging. Dr. Haar, the platform is yours.
Okay, great. Thank you, Chadi. So thank you for inviting me to present this talk. So again, entitled Cost-Effective Complete Revascularization with a single pressure guide wire. So the objectives of my talk are to demonstrate the use of physiological assessment in guiding the treatment of multi-vessel CAD. Also to illustrate cost-effective and cost-saving strategies using the Opsens OptoWire. So this is our case presentations, outpatient 70-year-old male presenting with dyspnea on exertion. He had a dobutamine stress echo demonstrating inferior hypokinesis on low-dose dobutamine stress, and he had persistent symptoms despite optimal medical therapy. And his past medical history, you can see there, he's had a previous PCI of his RCA about 7 years ago. And on the angiogram of the RCA to start, the stent remains patent. On the left, we have the cranial view of the left system, and on the right, we have the caudal view. So if I can get that to play again here. So the LAD has a moderate stenosis at the level of the septal there, and then the circumflex system has a longer stenosis present in the mid-vessel, spanning a couple of the obtuse marginal branches here. On further imaging here, we can see that there's a ramus branch that's present that appears to have a severe angiographic stenosis. We also get another view of the disease within the left circumflex. And then in the areocranial view, again, in the LAD near the septal, there appears to be a more significant stenosis just hiding right beside the septal perforator. So we have three potential lesions there, keeping in mind our dobutamine stress echo showed inferior hypokinesis. So I start off with a pressure wire of the LAD. So this is where we parked the pressure sensor of the Opsens wire. And then, so this is where the pressure transducer is on the Opsens wire. And the FFR here with the adenosine was 0.81, so just above the threshold for revascularization. Next, we proceeded with an FFR of the ramus, and as my fellow panelists mentioned, when you have a short lesion, that's where the FFR often will become unpredictable. And as Dr. Vo presented as well in FAME, we're wrong about 1/3 of the time on angiographic assessment. I thought for sure the ramus would be significant. But when we parked the pressure wire down distal beyond the lesion, the FFR was well above 0.8. Next, we did an FFR and a DPR pullback. And DPR is the diastolic pressure ratio that is used on the Opsens wire that you use in the same manner as you would in IFR. And you can see distally when we had the wire, the FFR was quite abnormal, 0.67. And then as I did the pullback, we had a couple of step-ups present. So we went from 0.84 distally. Beyond the first more severe stenosis distally here, it went up to 0.92. And then as we came around right up to the corner here, it was up to 0.95. So my plan was to try to stent from this location here and extend the stent down here in this long and angulated and calcified vessel. So the summary of the findings: RCA stent was patent. The moderate stenosis in the LAD had an FFR of 0.81. The angiographically severe stenosis in the ramus was actually had the best pressure wire measurement of 0.90, and then the circumflex had serial stenoses, and the pullback helped us delineate what we should be treating. So while staying on the Opsens OptoWire, so it's not as complex as the procedures that Dr. Vo does, but even in this situation, in the calcified and angulated vessel, the Opsens wire behaved enough like a workhorse wire that we were able to do PCI on it. Let's see if I can get this to play again. Apologies. So this is the before picture. And then afterwards, after deploying one drug-eluting stent, we rechecked the FFR and DPR afterwards. So the FFR had improved to 0.88, and the DPR was 0.96. So I was happy with the result. I opted to leave the proximal milder stenosis that had some calcium in it alone. And if you can recall, the defined PCI study had some subsequent analyses showing that the residual DPR of above or at least 0.95 was associated with a better outcome with less repeat revascularization and repeat hospitalization. So I was happy that I was above the 0.95 value. So in summary, this is an illustration of cost-effective complete revascularization with a single pressure guide wire. And so again, we used it like a workhorse wire to do our PCI on it. So it reduced unnecessary stenting in the LAD and the ramus. The Opsens OptoWire has workhorse-like characteristics, so we were able to do it all on a single guide wire. The DPR pullback allowed us to assess hemodynamic significance of the serial lesions. We can minimize stenting. And the OptoWire design is durable enough as well that we were able to manipulate it down 3 different coronaries, run NC balloons, a stent, and then another NC balloon to post-dilate. And we're still able to use it again to repeat a pressure wire measurement at the end with both DPR and IFR. And then in terms of how I could have further optimized the cost in this procedure, in theory, I could have not used adenosine and just relied on DPR for all 3 of the vessels, and that would have saved us a few $100s more in drug cost. So thank you. So I'd just like to open things up to my fellow panelists for any questions and discussion.
Thank you, Dr. Har. That's perfect. We have one more poll question coming, but really, I enjoy this webinar specifically. I mean, we can talk about physiology and how to wire and how to deploy a stent, but it's more focused on when you utilize tools in the cath lab, not just beyond the physiology wire. When do you want to do a microcatheter? When you want to use an IVUS? As Brian said, he's an expert in imaging. When do you do OCT versus IVUS? These things are, I think COVID was a wake-up call for us to understand how much we need to use and what to use. And it was a kind of testing us to the core to call the equipment that really we need. And Dr. Vu kind of hit on that. Stephen Ford, his comment was phenomenal as well. But I would like to kind of, have only 2 or 3 minutes left. Just final comments is what do you expect in terms of our practice going forward during COVID, and how is it going to change? We'll take it maybe one by one.
Sure, since I have my mic on for finishing the last talk, I'll go first. I think it goes in 2 directions. So, one example is to simplify things, which is what Dr. Ang had said. If you for a good example that he had was a bifurcation lesion. And there's many steps of the way that we could simplify things by doing a hemodynamic assessment. So he showed that you only needed 1 stent. But, in the situation as well where you have to jail your side branch and you pinch it off at the end, You can also assess your pressure wire measurement afterwards to see if you need a further intervention, because if you're FFR, after jailing your side branch angiographically, you often will end up with a severe stenosis, but if the FFR is normal, there's data to show that you're fine to leave that alone. So, you know, you can simplify your procedure and also assess if you need to do more, if you have a question. On the flip side, for your technologies and your added costs, similar to what Dr. Vo had presented, is we are getting referrals for more complex PCIs, so more bifurcations, more left main, more CTO. And if you want to make sure that the patient has as much of a comparable result to CABG or a CABG-like result, you need to optimize things, right? So you use your pressure wire to try to get as high of a FFR, DPR, IFR value, or whatever technology you're using. And you're also using intracoronary imaging as well to make sure your stent result is as maximized as possible to reduce your chances. You know, some things are uncontrollable, like a COVID-related thrombotic state, but you know, if you have you know, struts that are not fully opposed, or you have less than optimal expansion, and you're assessing that with OCT or IVUS, that will help you to further optimize your results. So A, you simplify your cases, but B, when you're doing your complex cases, it lets you make sure you have as ideal of a result with your complex cases as possible.
Absolutely. Dr. Vo?
For me, as a complex C2 operator, I don't like imaging or physiology, as I mentioned, but I've learned to like physiology and I have to adopt, and that's why I did that. In terms of do you image, I'm very comfortable not imaging, Brian, and I know imaging is very important for causes of ACS. For me, I'm comfortable with data post PCI, IFR, FFR. I think we need more of those data just to make more people more comfortable. We only have such limited data for post PCI. And as a complex operator, I need to make sure I'm doing the right things and the right job with the right result at the end. My only concern is that just talking about Opsens right now. So if I want to get the Opsens, if you guys have any solutions, you probably have previous webinars. You guys are late to the race in terms of FFR was way before the race that got started, then Opsens came afterwards. If people like myself have integrated system already, and we want the Opsens, what is the strategy to get that? And I know it's beyond the scope, but that's something to think about for future webinars if you haven't touched on that yet.
That's a very good point, Dr. Vo. I mean, this is not just Opsens wire, any new equipment. You have an IVUS for Philips, you want the Boston for better resolution, or vice versa, or you want an integrated lab Philips where you have the co-registration. We don't have it, and we're struggling to get one. All these, we don't have OCT, our IVUS lab. We requested it, I mean, before COVID, and then COVID came, guess what? I don't think I'm gonna get it in 2 years, maybe 3. So there's certain things challenging we present to the administration, but we did a webinar, just not the one before, is talking about the how to work with administration and stakeholders and the hospital to request for equipment, and how to make a case to justify for requesting this new equipment. So as you said, if you have something that's functional, that does the job, the chances of getting new equipment is going to be very low. If you show evidence by data, by publication, or by track record, or by a request by a body of interventions in the lab that say, you need this something done, or this closure device, for example, then maybe you have a better case. But we did a full webinar about that, and it was very engaging and interesting. And I would like to refer our audience to that as well. Dr. Ang, any final comments?
Yeah, I think this kind of ekes into the business of medicine, and you know, it's hard enough to be a physician, so I'm going to kind of like leave that question alone. But I think one thing that hasn't really been touched on is using FFR data as a continuum of numbers. And it really gives you a peek into the risk that a lesion portends. So like in Dr. Har's case, in my case with FFR values less than 0.7, you know that these lesions portend greater risk. If you have a FFR value right around 0.8, it makes you feel some comfort in leaving it alone, but you know that down the road, you may be revisiting that lesion. If you have a FFR value greater than 0.9, you know that the risk is much lower. And so you kind of get a glimpse into the future of how aggressive you need to be and what's the risk that the patient has for all of the different lesions that you are interrogating, which is really useful in my opinion.
And Lawrence, you are 100% correct. I mean, we don't learn this in medical school. We don't learn this in training, the business aspect of medicine. And unfortunately, we're learning it the hard way. Go ahead.
Just one thing I just thought of. So when I'm doing complex PCIs and we're discussing coronary physiology and all that, the other thing that I also started to do now is coronary physiology for CABG patients, because I've seen patients come back with difficult lesions for me to deal with CTOs when the lesion didn't need to be fixed or bypassed. So now I'm starting to do even diagnostic, and I'm concerned this lesion is not severe. Please don't bypass. I would do coronary physiology now and say only bypass these two lesions. I think that's the part that people are missing. They're thinking coronary physiology, PCI or not. But now coronary physiology, bypass or not. So I'm starting to do that more now. Again, especially in COVID, and especially I don't want to be dealing with these patients bypassed inappropriately and coming back with everything blocked. Now I have to deal with those. It's very frustrating.
Man, great observation. So this touches on the famous trial which helped you to change whether you want to send your patient to CABG or PCI or medical therapy. So it kind of touches on that. But also the FAME3 trial is going to answer this question of which lesions multivessel disease need to be revascularized. And I believe enrollment is stopped and just follow-up is still ongoing. So stay tuned for FAME3 results.
The same thing I would like to put a plug for the post-PCI IFR and how it's important to reevaluate after for optimization of your treatment and stents, whatever you've done to the vessel. And sorry for the overhead call. And otherwise, it's defined GPS is one of the trials that currently recruiting, which is, I think, it's going to be answering a big question with a cutoff of less or above 0.93 of IFR post PCI. I think that's another important study should be for the look for. Well, thank you so much. It's 2 minutes or 3 minutes after the hour. I really appreciate our speakers for joining us tonight. It was a phenomenal discussion. Thank you so much for preparing these cases. Great skills, great presentation, case-based discussion. I would like to thank Opsens for sponsoring this webinar series. And I would like to invite you for our mid-May webinar. We're going to be talking about physiology in the peripheral arterial disease intervention. And we have a host of panelists who's going to be experts in the field of peripheral as well as peripheral physiology. So stay tuned for that. Meanwhile, be safe and do good things. And thank you so much for joining us tonight.
Thanks, everyone. Have a great night.
Thank you.